Hello, my name is Teodora Dumitrescu, and I'm a director in the Clinical Pharmacology Modeling and Simulation Group at GlaxoSmithKline. On behalf of my colleagues from ViiV and GlaxoSmithKline, I am presenting 3 phase 1 drug interaction studies investigating the next generation maturation inhibitor, GSK 3640254, which I'm going to refer to as GSK 254, with oral contraceptive ethinyl estradiol, levonorgestrel, with dolutegravir and tenofovir, alafenamide, and emtricitabine. For more information, I can be contacted via email on the email address found on this first slide. My conflict of interest is that I am an employee of GlaxoSmithKline. As you all know, there is still a need for new therapeutic agents for people living with HIV to meet a variety of unmet medical needs. GSK 254 is a next-generation maturation inhibitor effective against a broad range of polymorphisms with no cross-resistance to currently approved antiretroviral HIV drug classes. The figure on the right shows the mechanism of action of maturation inhibitors as it was described last year and in 2015 at CROI. Since GSK 254 is expected to be co-administered with oral contraceptives DTG and TAF-FTC in a planned phase 2b study. Here we describe the safety and PK results from 3 phase 1 drug interaction studies investigating GSK 254 in healthy participants. The first study was GSK 254 oral contraceptive drug interaction study. In terms of the design, which is illustrated at the top of the slide, this was an open-labeled, fixed sequence, one-way drug interaction study, which consisted of screening period, a check-in on day -4, a short run-in period from day -3 to day -1, where all participants received a daily dose of Porsche, and a treatment period with Porsche given either alone for 10 days or together with 200 milligram daily dose of GSK 254 on days 11 to 21. All treatments were administered with a moderate fat meal. In total, 23 women were enrolled, the majority of which were not on hormonal contraception prior to the start of the study. In addition to serial PK samples for ethinyl estradiol and levonorgestrel, we also collected blood samples for progesterone, LH, and FSH, which are PD biomarkers for breakthrough ovulation. At the bottom of the slide in the table, we show the key PK and PD results, which show that co-administration of GSK 254 with Porsche in the presence of a moderate fat meal did not impact the steady-state exposure of ethinyl estradiol or levonorgestrel, as illustrated by a geometric mean ratio of AUC and Cmax of approximately 1 and a 90% confidence interval within 0.8 to 1.25. In addition, there were no clinical trends in serum progesterone, LH, or FSH consistent with breakthrough ovulation. Moving on, here is a summary of the safety information for GSK 254 oral contraceptive drug interaction study. The most common adverse events were transaminase increases and headache. With regard to transaminases, 8 participants had asymptomatic self-limited increases isolated to their ALTs and ASTs, 4 on Porsche and 4 participants receiving Porsche plus GSK 254. The figure on the right shows box plots of ethinyl estradiol, levonorgestrel, and GSK 254, segregated by the treatment either Porsche on Porsche or Porsche plus GSK 254, and with the individual PK parameters color-coded by ALT, with green being normal, yellow being ALT greater than the upper limit of normal, and red being ALT greater than the 3 times upper limit of normal, which is the stopping criteria. The fact that the spread of the individual PK parameters is similar for all ALT subgroups indicates that there were no discernible trends in the PK parameters in participants without or with ALT elevations. These elevations are likely to be due to newly initiated treatment with hormonal contraception. The second study was GSK 254 Dolutegravir drug interaction study. In terms of design, which is again illustrated at the top of the slide, this was an open label, fixed sequence, 3-period, 2-way interaction study, which consisted of a screening period, followed by period 1, where participants received 50 milligram DTG for 5 days, a washout period, and then period 2, where all participants received 200 milligram GSK254 daily dose for 7 days, followed by period 3, where all participants received Dolutegravir plus GSK254 for 7 days. All treatments were administered with a moderate fat meal. The key study results shown in the table at the bottom of the slide show that there is no interaction between GSK254 and DTG, as illustrated by the AUC and Cmax geometric mean ratio close to 1 and 90% confidence interval within the 0.8 and 1.25 for DTG and GSK254 when given in combination versus the reference. The third study was the GSK254 TAF-FTC drug interaction study. In terms of the design illustrated at the top of the slide, this was an open label, fixed sequence, 2-period, 1-way drug interaction study, which consisted of a screening period, followed by period 1, where participants received TAF-FTC alone for 14 days, followed by period 2, where participants received TAF-FTC with 200 milligram GSK254 for 7 days. All treatments were administered in the presence of a moderate fat meal, and the results shown at the bottom of the slide in the table indicate that co-administration of GSK254 with TAF-FTC decreased TAF exposure by approximately 11 to 12%. However, the exposure to tenofovir, which is the active moiety of TAF, and to FTC remained unchanged, as illustrated by a geometric mean ratio of approximately 1 and a 90% confidence interval for AUC and Cmax within 0.8 to 1.25. This slide shows the combined safety information from GSK254 drug-drug interaction studies with DTG and TAF-FTC. In both studies, most adverse events were grade 1 or mild, and there were no clinically relevant trends in adverse events, laboratory values, ECGs, or vital signs, indicating that co-administration of GSK254 with DTG or with TAF-FTC was well tolerated. In conclusion, the overarching conclusion for the 3 studies is that there were no significant PK or PD interactions precluding the co-administration of GSK254 with either oral contraception, DTG, or TAF-FTC, and that the results support the planned phase 2b study, with the recruitment planned for to start in October. Thank you.
Hello, I am Patel, Global Medical Affairs Director from ViiV Healthcare, and I'd like to thank the organizers for selecting our abstract for an oral poster presentation. CAB and rilpivirine long-acting are administered as 2 separate gluteal intramuscular depot injections from which the drugs are slowly absorbed into the systemic circulation, resulting in sustained plasma concentrations over a 1-month or every 2-month dosing interval. CAB is metabolized via UGT1A1 with a minor UGT1A9 component, and rilpivirine is metabolized by CYP3A. Importantly, neither are inducers or inhibitors of metabolic enzymes. For most drugs with a standard PK profile, the persistence of drug in plasma is dependent on the rate of elimination and not the rate of absorption. Elimination is determined by the metabolism of the compound, so changes to metabolism lead to changes in the rate of elimination, which then lead to changes in the half-life. In contrast, long-acting drugs, such as CAB and rilpivirine, have rates of absorption that are significantly slower than the rates of metabolism. This leads to the phenomenon of flip-flop PK, where the terminal PK is moderated by the rate of absorption instead of the rate of metabolism. The 2 figures on the right illustrate these concepts and the consequences of altering metabolism through induction or inhibition. In the top panel, the PK profile for a drug with flip-flop PK shows this parallel shift up or down in concentration time course with an inhibitor or an inducer relative to baseline. So here, you are changing the AUC, but not changing the half-life. In contrast, the bottom panel shows the typical situation for an oral drug with standard PK, where a metabolic inducer or inhibitor impacts the terminal phase of the PK profile, altering the gradient of the victim drug. So here you are changing the AUC and the half-life. Because CAB and rilpivirine are long-acting drugs with flip-flop PK, there are few clinically relevant drug-drug interactions during active therapy, as listed on the slide. So briefly, strong metabolic inducers are contraindicated, and caution is advised with sensitive O13 substrate drugs with narrow therapeutic index, such as methotrexate. Caution is also advised in individuals receiving chronic systemic anticoagulation given the IM modality of long-acting CAB and rilpivirine. Caution is also advised with drugs with a known risk of torsades. Following long-acting discontinuation during the PK tail, no drug-drug interactions with alternative heart are anticipated. And of note, metabolic inducers will not hasten removal of long-acting CAB and rilpivirine. Drugs that may be used without restriction with CAB-LA and rilpivirine LA include the following: hormonal contraceptives, HPV and most HCV antivirals, most antibiotics, including IM formulations, gastric acid modifying agents, and drugs for other comorbidities. This slide summarizes established and other potential significant DDIs with long-acting CAB and rilpivirine. Drugs that are contraindicated include potent CYP and UGT enzyme inducers among the class of anticonvulsants, antimycobacterials such as rifampin, rifabutin, more than a single dose of dexamethasone, and the herbal St. John's wort. So support for this guidance comes from a variety of sources as listed. In addition, alternatives to the macrolides clarithromycin and erythromycin should be considered because of the risk of torsades with these drugs. And then finally, clinical monitoring is recommended as methadone maintenance therapy may need to be adjusted in some patients during concomitant administration with long-acting CAB and rilpivirine. Lastly, this table summarizes recommendations based on predicted drug interactions with CAB plus rilpivirine LA and select drugs that are commonly co-administered in persons living with HIV. Again, strong or moderate inducers of CYP and UGT metabolism are contraindicated due to the potential loss of efficacy and development of resistance. No clinically relevant drug interaction is expected with UGT1A1 or CYP3A inhibitors and long-acting CAB and rilpivirine. And gastric acid modifying agents such as antacids, H2 blockers, and PPIs can be given with long-acting CAB and rilpivirine because parenteral dosing bypasses the GI tract, where this interaction is expected to occur. However, it's important to remember that these agents are still contraindicated or dose separation is required with the oral tablet formulations of CAB and rilpivirine. Thank you for your attention today, and for more information, I can be contacted via email, which can be found in this presentation.
Hello everyone, I am Katie Moore, Head of Clinical Pharmacology at ViiV Healthcare. On behalf of my co-authors, Ilana Post, Savannah Maju, Mindy McGee, Pete Garicki, Pete Ackerman, and Cyril Lamoso, I'm excited to share the drug-drug interaction profile of the recently approved fostemsavir for heavily treatment-experienced patients with multi-drug resistant HIV-1 infection. Fostemsavir has a very comprehensive clinical pharmacology program with 27 phase 1 studies and 1 phase 2A study, many PK, PK/PD, and PBPK analyses. And so this presentation will focus on the application of results from the in vitro metabolism and transporter studies and all the clinical DDI studies. So let's begin with the highlights and the objectives. Fostemsavir is an oral prodrug of temsavir. Temsavir is primarily metabolized by esterases with CYP3A4 metabolism as a secondary pathway. This is where temsavir is a victim of DDIs. Temsavir is an inhibitor of BCRP and OATP1B1 and 1B3, and its two metabolites inhibit BCRP. This is where temsavir is a perpetrator of drug-drug interactions. Importantly, temsavir does not inhibit or induce major CYPs, UGTs, or other transporters that are detailed here. So the objective was to summarize the fostemsavir drug-drug interaction profile to inform co-administration with antiretrovirals and other drugs commonly used to treat individuals with HIV-1. Drug-drug interaction results were used to examine the impact of 14 drugs or drug combinations on Timzavir pharmacokinetics, as well as the impact of Timzavir on the pharmacokinetics of 10 other drugs. The results were summarized and applied to drugs with common underlying mechanisms. Clinically relevant Timzavir drug interactions were based on Timzavir exposure-response relationships, which balanced the potential for Cmax-related QT prolongation while optimizing trough exposures for antiviral efficacy. Moving to the results, no significant interactions are expected across all currently available ARV classes: PIs, NRTIs, NNRTIs, integrase inhibitors, CCR5 inhibitors, and other entry inhibitors. And presented in the table to the left is a selection of these ARV classes and their impact on Timzavir. A full DDI profile for all ARVs is in the USPI. So let's take a closer look at strong CYP3A4 inhibitors, ritonavir, Cobi, boosted darunavir. As we know that Timzavir is a victim of CYP3A4, there is an increase in plasma TMR exposure up to twofold. For example, if you look at the last row with Cobi, there is a 1.93 increase in the AUC of Timzavir. But this does not require a dose adjustment because Timzavir Cmax remains below the threshold defined by the concentration QT relationship, which is more than 4-fold higher than the approved dose. Moving to moderate CYP3A inducers, similarly, with moderate inducers such as etravirine or rifabutin, there is a decrease in plasma Timzavir exposure. But this does not require a dose adjustment because based on exposure response modeling with the phase 3 data from BRIGHT, there were no clinically relevant changes in virologic response. Moving to common drugs used to manage HIV and HIV co-infections or comorbidities, there are a few drugs that require attention from the HCP. Staying with Timzavir as a victim, strong CYP3A inducers, such as rifampin, displayed in the first row of the table to the right, resulted in a significant reduction in Timzavir plasma concentrations. Of course, this may decrease virologic response, and therefore, strong CYP3A inducers are contraindicated. But remember, for moderate inducers, such as etravirine or rifabutin, fostimsavir can be co-administered. Now let's examine Timzavir as a perpetrator. In an oral contraceptive DDI study, there was a 40% increase in ethinyl estradiol exposure and no impact in norepinephrine. Because of this increase in ethinyl estradiol, we recommend the dose be less than or equal to 30 micrograms per day, and cautions advised for patients with additional risk factors for thromboembolic events. Because statins are OATP and BCRP substrates, we conducted a rosuvastatin drug-drug interaction study. And what we found was the 70% increase in rosuvastatin exposure with fostimsavir co-administration. Therefore, the recommendation is to use the lowest possible starting dose for a statin and to monitor for statin-associated AEs. And staying with that theme of Timzavir inhibition of OATP, although we didn't study these HCV agents, we anticipate an increase in grazeprevir and voxiloprevir concentrations, and if possible, use an alternative HCV regimen if possible. Lastly, since fostimsavir prolongs the QT interval at 4 times the recommended dose, caution should be used when co-administering drugs also known to prolong the QT interval. So in summary, fostimsavir can be co-administered with most common therapies used to manage HIV and HIV co-infections or comorbidities, including ARVs, drugs that increase gastric pH, strong CYP3A inhibitors, moderate CYP3A inducers, and therapies for opioid dependence. We'd like to thank all study participants and their families and the study investigators, as well as the scientists who contributed to this body of work over the years. Thank you very much for your attention and your interest. For more information, I can be contacted at the email address provided on the last slide. Thank you.
Thank you for the opportunity to present data for J&J 644-17184, which is a non-nucleoside inhibitor of RSV polymerase. The study was conducted in healthy volunteers. This was a double-blind, randomized, placebo-controlled study assessing single and multiple ascending doses of J&J 7184 in non-Japanese and Japanese healthy volunteers. Single ascending dose cohorts comprised of 8 volunteers, 6 receiving active drug and 2 receiving placebo. Non-Japanese volunteers were administered with either J&J 7184 drug product 1 at 40, 120, or 300 milligrams, followed by drug product 2 at 300 or 600 milligrams, or 300 milligrams of drug product 3, all under fasted conditions. After a 7-day washout, the same volunteers were administered 120 milligrams of drug product 1 and 300 milligrams of drug product 2 under fed conditions. Japanese volunteers were administered drug product 2 at 300, 600, or 900 milligrams under fasted. Multiple ascending dose cohorts comprised of 10 volunteers, 8 receiving active drug and 2 receiving placebo. Non-Japanese volunteers were administered multiple doses of drug product 2, consisting of 300, 600, or 900 milligrams once daily for 7 days, or a 600 milligram loading dose followed by 450 milligrams daily for 13 days, all under fasted conditions. Japanese volunteers were administered 600 milligrams of drug product 2 daily for 7 days under fasted conditions. For assessments, plasma samples were collected over 120 hours in SAD cohorts and over 24 hours on day 1 and day 7 or 14 in MAD cohorts, and analyzed using liquid chromatography with tandem mass spectrometry. PK parameters were estimated using non-compartmental analysis. Safety and tolerability were assessed throughout the study. Here, the mean plasma concentration time profile is shown for the SAD cohorts, including food effects. The terminal half-life of J&J 7184 was 17 to 22 hours across doses. Increases in maximum serum concentration, trough concentration, at 24 hours post-dose and area under the curve for 0 to 24 hours were dose proportional over the dose ranges for drug product 1 and drug product 2. Tmax ranged from 3 to 12 hours across doses and volunteers. Food increased exposure to J&J 7184 after administration of DP1 and DP2 and slightly delayed Tmax. Similar pharmacokinetics were observed in non-Japanese and Japanese volunteers. In MAD cohorts, steady-state concentration was achieved within 4 days with a 1.58 to 1.7-fold accumulation and exposure at day 7 relative to day 1. Tmax was 4 hours across doses in volunteers. Effect in Japanese volunteers were administered with 600 milligrams of DP2 daily for 7 days, whereby it was 2 hours. Exposure was approximately 19% less in Japanese volunteers at day 1 versus non-Japanese volunteers. Pharmacokinetics were similar between groups at day 7. In total, 12 treatment-emergent adverse events were observed during single dosing. All were considered mild or moderate, and only 2 were considered related to J&J 7184. No treatment-emergent serious adverse events were observed during multiple dosings of J&J 7184, and the 32 observed treatment-emergent adverse events were considered mild or moderate. We observed a similar number of AEs in drug-treated volunteers as those who received placebo. Dizziness was considered possibly related to high doses of J&J 7184 occurring at 900 milligram doses. In summary, single and multiple dose administration of J&J 7184 was generally safe and well tolerated in healthy volunteers. Exposure increased in a dose proportional manner. PK was similar for non-Japanese and Japanese volunteers following single dosing of J&J 7184, whereas for multiple dosing, slightly higher exposure was observed at day 1 in non-Japanese versus Japanese volunteers and was similar between groups by day 7. Multiple dosing achieved plasma concentrations within the anticipated therapeutic range of these healthy volunteers. Future studies will evaluate J&J 7184 in adults infected with RSV. Thank you for this opportunity to present our data.
On behalf of my colleagues, I'd like to thank the conference organizers for selecting our abstract as an oral poster. J&J 3989 is a fixed-dose combination of two small interfering RNA compounds, J&J 3976 and J&J 3924, in a 2-to-1 molar ratio. Both compounds can be represented by the single figure below. On the left-hand side of the molecule are 3 N-acetylgalactosamines, which serve as a ligand for the hepatic asialoglycoprotein receptor. The pharmacologically active portion of the molecule shown on the right is double-stranded RNA, 21 nucleotides in length. This is also referred to as the RNA interference trigger. The nucleotide sequences are complementary to the mRNA produced from the HBV genome, illustrated here. 3976 targets the S open reading frame, whereas 3924 targets the X open reading frame. Together, the two RNA triggers are designed to target all HBV RNA transcripts derived from covalently closed circular DNA, as well as transcripts derived from integrated viral DNA. Once delivered to the hepatocyte, the triggers are internalized and become loaded onto the RNA-induced silencing complex. The loaded RISC then cleaves HBV mRNA in a sequence-specific manner. This activity is continuous, allowing for once-monthly dosing. Proof of concept was recently presented by Dr. Gain at EASL last month. Patients with chronic hepatitis B were administered J&J 3989 100 to 400 milligrams subcutaneously every 28 days for 3 doses with nucleoside analogs. 39% of patients were able to sustain 1 log or greater reduction in hepatitis B surface antigen for 48 weeks after the last dose. Single-dose pharmacokinetics of J&J 3976 and J&J 3924 were evaluated in healthy volunteers from 2 phase 1 studies. ARO-HBV 1001 was the first in-human single ascending dose study evaluating doses between 35 and 400 milligrams in a non-Japanese population. For each dose, 6 subjects were enrolled, 4 on active, 2 on placebo. Subsequently, we designed a Japanese PK bridging study, the HBV 1001 study, to assess in parallel 3 doses, 25, 100, and 200 milligrams. For each dose, we enrolled 8 subjects, 6 on active, 2 on placebo. In both studies, plasma PK was measured over 48 hours. In the ARO-HBV 1001 study, we also collected urine PK over 24 hours. PK parameters were estimated using non-compartmental analysis, and a pooled population PK model was developed using non-MEM. Safety and tolerability were assessed throughout. In general, few adverse events were reported in both trials. The most common adverse event occurring in at least one healthy volunteer is provided in the table. These adverse events were equally distributed between active and placebo subjects. All adverse events were reported as either mild or moderate. Injection site reactions were reported in 4 subjects, 3 on active, 1 on placebo. In the upper right quadrant, I present the plasma concentration time curves for 3976 on the left and 3924 on the right. Solid lines represent the ARO-HBV 1001 subjects, whereas the dotted lines represent the subjects from HBV 1001. The colors correspond to the doses in the table. In the table are the derived pharmacokinetic parameters. On the top is J&J 3976 and on the bottom is J&J 3924. In general, plasma half-life was 4 to 6 hours for both compounds. In general, exposure increased in a dose proportional manner up to 300 milligrams. At 400 milligrams, it was less than dose proportional. When comparing the 2 studies, Japanese subjects at the 100 milligram dose appeared to have higher Cmax and AUC relative to the non-Japanese in ARO-HBV 1001. At the 200 milligram dose, both Cmax and AUC were comparable. Both 3976 and 3924 were renally eliminated in a dose-dependent manner. The amount excreted ranged from 20 to 42% of the dose. In conclusion, J&J 3924 and 3976 have short plasma half-lives consistent with other GalNAc siRNAs. This suggests rapid hepatic uptake. Plasma exposure generally increased in the dose proportional manner, and no clinically relevant difference in PK was observed between the non-Japanese and Japanese population. Renal elimination was dose-dependent, and single-dose subcutaneous administration of J&J 3989 was generally safe and well tolerated. Several phase 2 studies of J&J 3989 are ongoing in patients with chronic HBV or HBV-HDV co-infection. Lastly, I'd like to acknowledge the participants and the study sites, as well as my colleagues at Janssen and Arrowhead Pharmaceuticals. Thank you for your attention.
Hello, I'm Joris Vandenbossche. On behalf of my colleagues at Janssen, I'll be presenting results of a study on the effect of multiple dose itraconazole on single dose J&J 6379 pharmacokinetics. 6379 is a HBV capsid assembly modulator that induces formation of normal but empty non-functional HBV capsids, CAM-normal, thereby blocking HBV replication. 6379 also inhibits de novo formation of covalently close-circular DNA, secondary mechanism of action. In ongoing phase 2 studies in chronic hepatitis B patients, 6379 is combined with J&J 7376-3989, short interfering RNA, a nucleoside analog as well as PEG interferon alpha. 6379 is mainly metabolized by cytochrome CYP3A4, is a CYP3A4 inducer and a substrate of breast cancer resistance protein as well as P-glycoprotein. 15% of an oral dose of 6379 is eliminated as unchanged drug in urine. Therefore, there is potential for drug-drug interaction when J&J 6379 is co-administered with a CYP3A4 inhibitor. Itraconazole was selected as potent and competitive inhibitor of CYP3A, but also is a substrate of CYP3A4 and a potent BCRP and P-glycoprotein inhibitor. In healthy adults, we investigated the effect of itraconazole after repeated administration on the PK of a single dose of 6379 and safety of the combination. Study was open label with a fixed sequence and recruited in a single center. Design figure. Treatment period 1, a single oral dose of 6379 to 50 mg given with food. A washout period of at least 33 days allowed for elimination of 6379. Treatment period 2, itraconazole given 5 times a single oral daily dose of 200 mg fat condition. Treatment period 3, single oral dose of 6379 to 50 mg given together with food while itraconazole was continued up to day 54. Follow-up was 33 up to 38 days after last administration of 6379. Results. 16 volunteers enrolled, 3 discontinued prematurely, 1 in each treatment period. PK parameters were evaluated in 16 subjects for reference, 14 for test. Figure with mean plasma concentration profiles illustrates that plasma concentrations of 6379 were higher during co-administration of itraconazole compared with those following 6379 alone. Table with PK parameters. Presence PK parameters of 6379 in absence of itraconazole as reference and in presence of itraconazole as test. Differences were more marked in the elimination phase captured by AUC 0,408 hours versus the absorption phase. Mean total amount of 6379 in urine was 1.30-fold higher and renal clearance 1.50-fold higher during co-administration with itraconazole. Statistical analysis. During co-administration, Cmax was slightly higher, as well as initial AUC 0.72 hours, still within 81-25% limits of confidence interval. Differences became more pronounced for AUC 0.408 hours. Ratio for AUC was about 40% higher and outside 81-25% limits. Pre-dose itraconazole plasma concentrations increased between day 36 in period 2 and day 55 in period 3 from 61 to 527 nanogram per. Safety. Treatment emergent AE were mild to moderate in severity, with headache most common. On last day of treatment period 2, one subject was discontinued by investigator after observation of increased amylase assessed as a grade 1. In treatment period 3, one volunteer withdrew from the study due to a serious AE. This was a grade 2 pneumothorax, categorized as unrelated to any treatment. Subject received 2 doses of 6379, 18 doses of itraconazole. Only treatment-related adverse event, hypercholesterolemia in one subject, considered as possibly related to itraconazole, doubtfully to 6379. In conclusion, co-administration of multiple doses of itraconazole with a single dose of J&J 6379 moderately increased exposure of 6379. It is expected that a similar increase of 6379 will be observed during co-administration of multiple doses of a CYP3A4 inhibitor and 6379. Single dose of 6379 with or without multiple dose of itraconazole was generally well tolerated No clinically relevant dose or concentration related safety issues. Thank you.